That ma'am, we are live.
Joined.
Namaskar and good evening, everyone. I welcome you all for today's webinar on lung cancer. And with immense pleasure, I would like to invite Dr. Deni Gupta, who is Senior Consultant Medical and Hemato-Oncology, Dharamshila Narayana Super Specialty Hospital, Delhi, for the welcome and introductory note and to take the proceeding further. Over to you, sir.
Yeah. Thank you, Shankar. So good evening, everyone. So all of you are here. So today's talk is on lung cancer. So we all know that why it is important. It is nothing new that it is the most common cause of mortality if we talk about all the cancers together in both sexes, male and female together. So 85% of our lung cancer are non-small cell lung cancer. And in this area, we know that there is a lot of mortality and research is going on in last, I think, 1.5 decade in all directions to improve the best possible outcome in advanced stage NSCLC. So in all possible direction means we were using a lot of chemotherapy earlier, paclitaxel, docetaxel, gemcitabine, nevelbine, so many chemotherapy, but there were no advancement as such the technology. In recent last few years, we have come up with the nanoparticle technology. We'll touch upon that part in this CME. Apart from that, immunotherapy is there, in which there is a VEGF inhibitor, PD-L1 inhibitor. We are not touching upon that in this talk, in this CME. And last is the molecular targeted therapy, on which we are touching upon, particularly about the EGFR mutation. So we have broader panel, and our panel is broadening day by day, including more and more markers: EGFR, ALK, ROS, NTRK, MET, RET, HER2. So many markers are coming up. With this advancement, I think there is a due course of time. There is a strong need that we do the comprehensive profiling, comprehensive genome profiling, and we have included this talk. And first talk will be delivered on this topic only by Dr. Dipanjan Panda. And after that, there will be a talk on what are the best options for EGFR mutant NSCLC. I think 1 or 2 talk, and then panel discussion on this topic by the Dr. Shyam Agarwal. So to start the CME program, so first topic is the on comprehensive genomic profiling. And to start this talk, I would invite Dr. Samir Khatri to chair this session.
Yeah. Hi, Danny.
And, hi, sir. Hi, sir.
Thank you for inviting me. So, as Dr. Danny has rightly pointed out, for the years together, we have been using chemotherapy left, right, and center in lung cancer, especially metastatic, and it has shown to be effective as far as the quality of life and the survival is concerned. But over the past 15-20 years, we have come across various targeted therapies also. And so definitely the genomic profiling, genomic testing, the precision medicine, it has come into vogue now. And every decision in lung cancer is now based on the genomic profiling, the comprehensive genomic profiling. To highlight these aspects, I will like to invite Dr. Dipanjan. Dr. Dipanjan Panda.
Yes,
so
yes.
He needs no introduction. He is a senior consultant at Apollo Hospital, and he will be talking about the panel discussion about the genomic profiling. Over to Dr. Dipanjan.
Thank you, sir. Samit sir. So first of all, my candid declaration: I'm not an expert of comprehensive genomic profiling, but the good thing is that I think most of the medical oncologists are no expert. So when I was given this task, I initially asked why I was, but then I understood that ultimately it is us who will be writing those prescription. And if this discussion help us understand what to do and when to do, then it will benefit us. So ultimately I agreed. So I'll just come to my, this is always a problem with where to find your stop. Just give me a second.
So if you want, we can share from our side.
Just give me 1 second. I will just close it once and then rejoin. Just give me 1 second.
लिलिया का सेशन दिखा दो.
एक minute. I think I've got it. Just a minute.
So you have so many slides, Dr. Panda.
No. I actually, this is basically the problem is, this is basically a problem with MacBook.
Yeah, same here.
So is this one? No.
So you can stop share your screen and then you can share it again.
I'll do that. Stop share and do that. Just keep it.
Yeah, it's here.
Just I need to find out that. It just take 1 second. Oh God, where did I put it? It is in file. I'm seeing.
May I share the screen for you?
Yes, you may, but the problem is that case study, Deepanjan Panda, PowerPoint presentation. I can see it. It is here, but I'm not being able to locate it in the. You can do it. You can do it.
Okay, sir.
Actually, I have changed some of the slide, but that's not a problem. Can you go to the next slide? What did so happen here? I'm not being able to. Oh, I have been able to locate it, Mahima. Can I share it? I've been able to locate it.
Sure, sir.
Just a minute. I have just located my slide. Can you see my slide?
Yes, sir.
Yes,
Yes,
it's
sir.
visible.
Yes. Sorry, I'm as far as I'm a little technologically challenged, and Apple doesn't suit me. But anyway, so
But you have doubled the slide.
So yeah. So I decided to plan this from clinician. Yes.
Deepanjan, first, will you like to introduce your panel?
Oh, yes. So sorry, actually. So I have the honor and privilege to call upon Dr. Piyush Bajpayee, who I know for close to a decade. Dr. Bajpayee, I believe, is in Manipal Hospital. He's
Hi, good evening.
Senior consultant. Dr. Nagendra Sharma. Nagendra, you are in Medanta?
I was in Vedanta, sir. Presently, I'm in Max Hospital, Saket.
Max Hospital. Yes, Nagendra has moved to. Sometimes and we also have Dr. Deepak Bharti from Patna. Dr. Deepak is here, right? Dr. Deepak, are you there? Hello. I am not sure. I am getting Dr. Deepak Bharti is here or
Sir,
not.
Yes,
Dr.
sir.
Deepak sir is here.
Dr. Deepak is here. Okay.
Dr. Deepak, unmute yourself.
And we also have Dr. Amit Sherawat, who I believe is the presently assistant professor, associate professor of medical oncology at AIIMS Rishikesh. Dr. Amit, good evening.
Yes, sir. Good evening, sir.
And Dr. Lalit Sharma, who is a medical oncologist from Jaipur. Hi, Dr. Lalit. So it's an honor and privilege, and I know most of them knows more than me. I am a little way, but the advantage of being a moderator is that you are the guy who asks questions. Anyway, So, about molecular profiling, while testing molecular profiling, I believe my dilemma or dilemma of a clinicians are 5 W's. They are what, why, when, where, and who. So I will start with that why. So Piyush, a very, very basic question. Why to look for molecular profile? Why should we look for molecular profile of a lung cancer?
So, I mean, as the chairperson also introduced that, until unless you identify the target, you might not be able to just do the clinical distinction like what IPAS did, looking at the clinical parameters and choosing your patients. So I think so we have come a long way. The technology has evolved. We have this everywhere in terms of technology, better technology to identify the genome better and give the drug and drug it appropriately, the mutant or the driver mutation. So why not do it? And so
okay,
probably
so Piyush has said that since we have come a long way from like artillery firing to a sniper, and we need a molecular profile for a better personalized care. Dr. Nagendra, now, those molecular studies can also be done, in various ways, like PCR. We can get some of them on IHC. Then why we need NGS or next generation sequencing?
Right. So as Dr. Piyush have told that thoracic oncology in last couple of years have undergone a rapid transformation, and we have come a long way. Previously, lung cancer used to be very simple cancer to manage, but right now it is one of the most complex as far as oncology is concerned. There are evolution in multiple phases, multiple facets are there in that, and next generation sequencing is one step forward. Comprehensive genomic profiling, NGS, we can do through Indian labs or international labs. The reason is we don't want to miss the targetable actionable mutations, because these mutations we have picked up, they are having a better PFS and overall survival if we use them rather than using the doublet chemotherapy, which used to be standard of care in these patients. That's why we want to know more and more about less and less, so that we can give better care to our patients. That's why, and right now we are going in an era in which the co-occurring mutations also we can pick up.
Nagendra, I basically wanted to know why, what is the advantage of NGS as a platform than otherwise looking for the other test, by PCR. You can do many of the tests by PCR. You can do some of them by FISH, molecular profile. You can do some of them on IHC also, looking at not the genomic status, but the proteomics. So why NGS?
So only thing is, by doing the fragmented test, we can figure it out that whether the patient is EGFR driven, ROS driven, or BRAF or ALK driven. By doing the comprehensive genomic profiling, we will get additional information also, like we can know about the PD-L1 status, we can know about the TMB, we can know about the co-occurring mutations.
Okay.
Or the sensitivity and specificity of the test is much higher.
So basically, Nagendra, you want to say that with doing test in sequence, we might also lose time as well as tissue. NGS will give us more information in a smaller thing. Dr. Dr. Deepak. Now,
yes,
you can do a targeted gene sequencing also, and you can do a comprehensive gene profiling also. So my question is, why should I be doing a comprehensive gene profiling with looking at a whole exome sequencing, or at least not whole exome, a large number of genes? Some people say 300, some people 500. I sometimes get confused. So why it's comprehensive genomic profiling? Why not just target few genes?
So basically, in the last 2-3 years back, we are doing only EGFR class only. And as the time evolved, we are doing BRAF, target mutation, NTRK, MET also is there. So basically, if you ask me in the real scenario, we are not doing comprehensive at present. We are just doing 30-40 genes only, hotspot genes only, for which we have the drugs to target upon. But as the era of this guidelines of NCC and ASMR all have been clearly to this comprehensive genomic profiling. But at present, if you ask me in lung cancer, still there's a way we want to regarding to that also, because we are not drugs are available for all the mutations which we are going to found in all this profiling. So if you ask me in a regular scenario, we are still doing that 7 or 8 mutation testing only. And if you ask me, that's hotspot 20, 30, 40 genes only. But for that comprehensive 200, 300 genes, it is still way far beyond, and I am not into it.
Okay, great. Dr. Amit, so can
Yes,
you
sir.
also take this? Why NGS and why comprehensive genomic profiling? Do we need to do NGS, or do we need to do comprehensive genomic profiling?
So first regarding NGS, so the more we know, wiser we are, and earlier we know, earlier we are wiser. So NGS will give you opportunity of multiple targeted therapy options over a shorter period of time, and we will be getting a comprehensive mutation profiling picture of lung cancer. And mostly we are getting useful information by targeted NGS, targeted mutation profiling. NGS provides that information in a more comprehensive way. So practically, whether getting more gene mutation, more information like comprehensive genetic profile is going to change our standard of practice to majority of the patient? The answer is no. So yes, theoretically that is providing better information, but practically are we going to use that information for most of our patients for making our practical decision day to day? So the answer to that is no. So practically, I think NGS profiling is suitable to most of our needs in our day-to-day clinical practice as of now.
Okay, Dr. Lalit, do you have anything more to add on this?
Yeah, so one additional advantage which NGS gives us is that it provides us many answers in a single go. So most of the times tissue is an issue, especially in lung cancer patients, wherein once you have done the initial histopathology, then ran IHC for the histopathology, then you are running tests, suppose for the IHCs of the most common mutations. And finally, when there is no tissue left, by the time we come to NGS and all, maybe probably there is no tissue left. So once we go for NGS at the very start, probably that scarcity of tissue issue might be addressed. One. Two, to some extent, we can say that the sensitivity and specificity of this test probably is far more compared to the other modalities. Third, a lot of information can be generated in a single go. Now that a lot of information in a panel form, targeted form might be very helpful, but many a times this might land up in some trouble also, that when multiple mutations are being found to kind of identify which is actually the driver mutation might become difficult, but that is usually in the rare scenarios. Most of the times the answers will be crystal clear. Now this additional information in the comprehensive manner which we get, that definitely helps us in the research scenario to understand our epidemiologies and the way things are going. But practically, probably most of us struggle with what to do with that additional information.
Okay. So if I have understood from all the panelists that what I understood, that we have come to a time of personalized cancer care. And what I have, small thing I've reviewed, that in the last decade or so, with the advent of discovering molecular alterations, especially EGFR and ALK, there is a rapid decline in mortality. We have got now druggable oncogene, and each tumor in person is unique. So we are coming to a personalized therapy. Now, these targets can also be checked with some other methods. But as Dr. Lalit has rightly pointed out, this terminology I first heard about almost 15 years back by Dr. Chandra Bellamy in a meeting when I was still a student at All India Institute, that tissue is an issue. It will always remain an issue. Although with liquid biopsy, things are becoming a little better, but it is still very expensive and limited in scope. So tissue, as long as tissue will remain an issue, we would like to use minimal amount of tissue and get as much as possible. Yeah. And next generation sequencing is definitely help in that. Now, the next bigger question is whether we do a targeted gene profiling or a comprehensive gene profiling. As we go further, I think we'll get some more glimpse on that. So what to test? So this question has already been discussed a bit. But I would again ask Piyush. Piyush, so what sort of test you want? Targeted panel, comprehensive panel, liquid biopsy?
So
Lung
I would say
cancer. We fixed ourselves to lung cancer.
Yeah. So I would say that it would again depend on what patient are you looking at. So if my patient is on severe oxygen support, I would look at quick answers, which is very difficult to actually get on NGS at times, and therefore probably the way over here is to look at specific panels. So most prominently EGFR, ALK, ROS should not be missed out now, BRAF as well. So these four combinations I would at least want an answer on, and this is now possible, with either on a cell block or whatever, where you have a minimalistic tissue with a patient being on oxygen support at times. So if the patient is mildly or moderately symptomatic and can undergo a biopsy with a good core, and can pay for that. So I think so I will go for a comprehensive genomic profiling upfront. I mean, it is all very relative, patient dependent, no straightforward answer on either of it. Comprehensive genomic panel definitely gives more information. There is no doubt about that. But most of the actionable information in the first line comes from these four markers majorly for Indian practice.
Okay, so I completely agree with Piyush that, by the way, NGS is a platform, so we can do even targeted gene profiling with NGS. But yes, if you do a comprehensive gene profiling, which might give us some more information, but sometimes we do not know what to do with those information, except few cases where the tumor mutation burdens can be checked. And most of the cases, I think 90% of our cases, targeted panel works. Nagendra, what about liquid biopsy? When you do liquid biopsy?
Right. So that is the very pertinent question, sir, especially in the era right now. So majority times we always prefer and go for a solid biopsy or wherever possible. But many times when the patient comes in a very poor performance status, directly lands up in emergency and directly go to ICU, in which you are not able to do a solid biopsy. Only FNAC from the cerebral node we are able to do, and that came out to be metastatic carcinoma or adenocarcinoma, and patient is having a lung mass. So in that scenario, when you are already having a FNAC proven cancer in advanced stage, we will go ahead with liquid biopsy and take call on that particular patient, because this circulating tumor DLNs are shed from the primary tumor and they are circulated in the blood. So in ml, in 7.5 ml of peripheral blood, we can take and circulating tumor cells if they are more than 5 or below 5. That and then other information also we can do through liquid biopsy, but only in this scenario. If you given me choice, answer is whenever possible we should go for a solid biopsy and prove it, and then do comprehensive genomic profiling in ideal circumstances. But if turnaround time and cost is an issue, then go for a limited panel or coupon testing for that matter. And if the patient performance status is not allowing you, and turnaround time is very short, go for a liquid biopsy and check for this mutation and document that clearly. This is the reason why we have done liquid biopsy and move forward. That's the way I look at it.
Okay. Dr. Deepak?
Yes, sir.
What are the conditions when you look for liquid biopsy in your center? Or have you doing it, or you are not doing it?
Sir, practically I'm not doing it, but only one indication is there. This is just like any patient who are getting a recurrence on EGFR, just to do for T790M mutation. This is basically just for that we are doing in our center.
Okay. You know what Dr. Nagendra has also pointed out, sometimes become difficult to biopsy. Suppose one patient who has acute breathlessness, you cannot do a bronchoscopy guided biopsy because there is a small but definite risk of that patient going into ventilator. Also, sometimes even for peripheral tissue, because of the vascular aberrations tissue, sometimes it is risky to do a CT guided biopsy, or sometimes you are not very sure that primary tumor size is small. So sometimes do liquids, and of course, as you said, in recurrence, especially in EGFR mutated patient, when you're looking for a new mutation, getting a repeat biopsy may not be feasible. And that case, for T790 mutation, Yes. Piyush, ctDNA or circulating tumor cell?
ctDNA.
Okay,
ctDNA. Yes.
ctDNA. Dr. Amit, ctDNA or CTC?
Practically, we are doing ctDNA only, sir. And indication wise, other than research purpose, the only two indications we are practically using. One, when tissue access is very difficult in upfront setting, or one patient is progressing on TK to see the mutation. These are the two settings in which practically we are doing.
I think that is true for most of us. If there is something else, you please let me know. Dr. Lalit, anything else about these things?
No, I agree. Most of the things have been covered by the article.
Okay. So whatever understood from this, yes, somebody wants to say something? No. So whatever I have understood from our August panelists, that they look for tissue, and when there is a turnaround time is an issue, or patient has a financial issue, then a targeted panel. But otherwise, if money is not a factor, they would also like to know other mutations, whether actionable or non-actionable, including tumor mutation burden, for which I think comprehensive genomic panel profile is a better option. And liquid biopsy is mostly when the tissue access is not there, or if there is a progression on a patient who are on EGFR TKI for other TKI. Any role for germline testing? Piyush, any role for germline testing in lung cancer?
Well, I have not got it done so far, but yes, the literature does mention that Li-Fraumoni is one rare situation where you can actually consider that. But I personally no personal experience.
Yes, I don't think we have a dedicated familial cancer syndrome clinic. I also haven't done it. Has anyone done a germline testing for lung cancer?
No, sir, but guidelines suggest that to be done when upfront patient is diagnosed to have T790.
I really am not aware of that, honestly. But yes, if there is some suspicion of a hereditary cancer syndrome, then of course you can think of as germline testing. So these are the data which I went through few articles, and I found these are the that with comprehensive genomic profiling, you can do a multiple actionable target with small amount of samples, and thereby you improve the success of the test. And so basically, the implementation of comprehensive genomic profile, it challenges that there are multiple gene panels and specific laboratories. So that also remains a, this is quite challenging regarding DNA extraction, sequencing, hybridizations, and so different platforms. So that also I will come to a question, that what platform, what place, but that will be my last question. So when to order an NGS test, or when not to order an NGS test? Dr. Lalit, can I start with you? When you should not be ordering an NGS test?
One is, as we discussed, it's not like not ordering, but maybe not just waiting for that. One is when there is an urgency, where probably other methods might give you an early answer. Huge contraindication, I'm not really aware of.
Amit, when you will not be doing NGS test?
So when we are not sure whether we are going to use that information or not. For example, if patient is not affording, or patient performance score is not that good, that we are going to offer anything to that patient. Otherwise, I don't think practically that we offer to any patient of adenocarcinoma.
So non-metastatic disease, do you do upfront NGS?
I was discussing about metastatic setting. In non-metastatic, as a practical point of view, we are not doing.
But you know, there has been, there has been some data that you can do osimertinib as an adjuvant therapy, right?
So for that, we only require EGFR status and PD-L1 for adjuvant atezolizumab and osimertinib. Nothing else we require to decide on that.
Yes. So you can do that from IHC only, right? You don't need a
PCR, yes, sir. We can do by routine methods instead of going for comprehensive.
Absolutely.
Unless we are doing as a part of research project.
Piyush, you want to add something else?
Yeah, I think so. What Dr. Amit said rightly. Just to add to it, probably if we are only having a bone tissue, I would not prefer a NGS. Rather, I would go for the immunohistochemistry based assays rather than.
That's a very, very important point, Piyush. I don't know whether how many students are listening to it, but you see that decalcification process damages the tissue DNA. So a bone is not a good tissue for anything, for that matter, molecular study. So if possible, try to get a tissue. Doing NGS on bone tissue can really gives you false negative result. So that's good. I'm very happy, Piyush, you point that out. And of course, as our other panelists have indicated, for a very poor performance status, rapidly progressing disease, and a very short expected lifespan, you really, I don't know. Sometimes, you know, they do really well, but if for a terminal patient, it may not give us any extra value. So these are the ESMO guidelines I got, that EGFR mutations, their exon 19, exon 20, and point mutation in exon 18, exon 20 insertion for EGFR. It's a difficult one, and of course there is ALK, MET, exon skipping, BRAF, especially V600E and ROS1. So,
Sir, can I come in?
Yeah, sure.
So just one indication which where we are not considering is the terminal one. So though this is anecdotal, but during the residency we had just one patient who was on EPMD and considered to be terminal, and then the EGFR mutation status turned out, and she was transferred on and ultimately extubated and then discharged well from the hospital, survived for say another 18 to 20 months. So I don't know.
You are actually very right. These slides, what they've said in terminal cases, when chemotherapy is not an option, if the patient has a mutation, sometimes that targeted therapy can really do wonders. So I completely accept your point. And we also have said, in fact, I had a African lady, she had a carcinoma unknown primary, is a huge liver mass. Ultimately, we did an NGS, found to have an ALK mutation, and she was sort of a chemo-refractory disease, and with that crizotinib, the liver actually started shrinking, and I met her after 6 months, and she was much better. I mean, yes, absolutely. So these are the ESMO guidelines for the common mutations which we can use: EGFR, ALK, MET. Now we have capmatinib here, BRAF, ROS1, NTRK, RET. Now selpercatinib has, I just reviewed their product information, and now selpercatinib has been become the next tissue agnostic drug. It has been all RET fusion solid tumor who have progressed after first line and have no alternate treatment left. You can use selpercatinib. And I have also reviewed, I have a case of gastric cancer with ALK, EML4 ALK mutation, for which I reviewed some literature and found there is already some data that in these cases you can also use either alectinib or crizotinib. So maybe when you are left with nothing, these drugs can actually work. Well, so these are the summary recommendations. I don't want to. So who to test? So there is a consensus guideline. I think we have already discussed all patient adenocarcinoma. Adenosquamous and squamous histology. Dr. Lalit, do you test squamous cell cancer?
Yes, sir. I do.
You do. So what is your positivity rate you have seen in your case? I mean, of course, we don't have a big number, but how many have you seen any?
We haven't compiled the data, but I believe the rates are more or less kind of between anywhere between 5 to 10%.
I believe 5% is something of a number which I discussed with Dr. Kumar Prabhas. That is the status data. And Dr. Amit, do you also test for squamous cell?
Yes, sir. We offer, and number is not that high for our experience. It's just around 2-3% in squamous cell.
Nagendra, what about your side in Max? If the patient comes out with squamous cell, you still offer NGS? I think we have lost Nagendra. Piyush, you want to take that call?
Yeah, we do check squamous cell, Dr. Dipanjan, but I would do more of a limited panel over there rather than a very extensive one. I mean, of course, until unless I would be looking at the tail end mutations and TRK, but I think so. So it again would depend on the logistical financials of the patient, and so those things would figure in. Yeah.
Yes, I agree with you. I also do a limited NGS, not the full CGP.
Yeah, hotspot, something like that.
Yeah. Because even if it is 5%, for that particular person, it can make a difference. So this is one of the case which was shown to see that advantage of CGP. It's a 45-year female, moderately affordable, non-smoker, cough, and you can see large left lung mass, and also there is a, if I can show you the right lung nodule, and there is a left acetabular mets. So left lung, mediastinal lymph node, bilateral pulmonary mets, renal mets, reticular lymph node, skeletal mets. So it was an adenocarcinoma. So these are the options were offered. Only EGFR ALK-ROS plus PD-L1, NGS for a panel, or NGS for a CGP. So as I have discussed, that possibly we could do for a CGP, but then affordability. Anyway, this patient did NGS for a panel of 546 genes. So this patient come over with a HER2 exon 20 mutation. So Piyush, do you think it was worth doing this NGS? Hello, Piyush. Hello, Nagendra. Am I audible?
Yes, sir.
I think we are somehow lost connection with our Dr. Amit. Are you listening? Can you hear me?
Yes, sir. You are audible, sir.
So do you think that in ERBB2X mutations coming out, will that help in this case?
Not specifically, sir. I don't think so.
So this patient, they were offered, I think, Pemetrix at carboplatin with pembrolizumab versus trastuzumab deruxtecan. I don't know whether this get trastuzumab deruxtecan. But for me, I think sometimes we do get these sort of mutations, but then again, the question will come, even if there is an HER2 mutation or HER2 amplifications, whether the patient will have access to a medicine or not, and whether that is what. So if I understand from all of you, and pardon me if I'm wrong, that a comprehensive genomic profiling considering 500 plus genes still remains more of an academic exercise. And most of us, because of a smaller turnaround time and cost issue, will going for a limited NGS profile considering actionable mutations. Am I right, Piyush?
Right. Dipanjan is also here. No, he's.
Hello. Piyush is talking to somebody else, I think. Nagendar, can I have you? Hello.
I was doing that, yes. I saw that.
Dr. Nagendar, are you there?
Sorry to interrupt, Dr. Dipanjan. Actually, just wanted to inform that you are left with only 2 minutes.
It's all right. So I think we are done. I've just wanted to ask the one last question. This is my question. So how do you choose where to send? So everybody can give their opinion. How do you choose your lab? Can Dr. Amit, how you choose your lab?
Affordability, availability, and availability.
Affordability, availability, and
Affability.
affability. Very good. Amit, I could not make it better. Dr. Lalit, what is your idea of choosing lab? How you choose?
Well, I would usually stick with the already established labs rather than choosing the new Muslim labs to use standard of care. I'm not really comfortable with because I don't know how well they are doing it and all. So affordability, I believe if someone is considering for these tests and all, so affordability usually is actually not an issue with them. Only in whom we are contemplating such therapies, we usually go with these tests. So I would be okay kind of spending a little more with a more established lab rather than the ones who are using.
Do you look for which platform they use, whether they're using Illumina or something, if they have published any paper, or who are the person behind them? Do you look for those ideas? That
I don't look to that, but I don't have any hesitation in admitting that we are also into a learning curve at this point in time regarding this. What to do and
do you discuss with your colleagues about what is their experience with different lab? Because some of them, sometimes when some of our colleagues has some positive or negative feedback, that also gives us an idea. Or person from high volume centers who are whatever they are doing, or which labs they are testing, those sort of things.
So far, I haven't had any such.
Nagendar, how you choose your lab? Any feedback? So I think Nagendar and Piyush is somewhere. We are not getting them. Dr. Deepak, this is my last questions. I think there is some problem. I think we do not have any more time left. So if I understand from all these discussions, is that all panelists have agreed that molecular profiling of lung cancer is an essential component in our treatment, especially for advanced lung cancer, more for adenocarcinoma, but if possible, we'll be also doing for squamous cell cancer. Comprehensive genomic profiling is desirable, but cost and turnaround time is something which we have to look for, and most of us are doing targeted NGS panel. And I think while choosing our lab, we will be looking for a lab who is established, have a good reputation, preferably have some published content, some good staff manning their lab, and of course, quick turnaround time. So with that, I end my talk, and I thank all my panelists for being there. Thank you, Lilac, for giving me this opportunity. Thank you.
Thank you, sir.
So thank you, Dr. Dipanjan and all the panelists for bringing out all these beautiful aspects about molecular testing in lung cancer, which we are sometimes confused what to test, when to test, where to send samples, all these things we have discussed. Thank you, Dr. Dipanjan. So after this, we move on to next topic, which is about a talk on decoding treatment options for EGFR mutant NSCLC patients. And this talk, I'm taking this talk myself, and so trying to upload the screen. So my slides are visible or not?
Yes, sir, it's visible.
Sorry, just a minute. So this is the talk which I am going to speak on decoding treatment options for EGFR mutant NSCLC. And this is the hospital where I'm working, Dharamshila Narayana Hospital. So we all know that as per the Globocan data, this is about the incidence. First pie chart is showing about the incidence. We all know that female breast is the most common variety, and then lung is the second most common. And if we talk about the mortality, lung is the most common out of all malignancy, 18%. And then colorectal, liver, stomach comes down the line. So this is the incidence as well as mortality. Then if we come across any lung cancer patient, NSCLC patient, so what all the parameters which determine the choice of first line treatment in this scenario? So whether it is progression-free survival, which we look into it, or oral survival, or oral response rate, whether patient is having brain metastasis at de novo or not, what are the safety and toxicity profile of a particular drug, quality of life, and patient receiving subsequent therapy upon progression. So all these parameters are there, which helps us in deciding the treatment option, which one to choose upfront. So if we talk about all the EGFR TKIs, first generation, second generation, third generation, so they are very beautifully color coded. So blue one is the first generation, gefitinib and erlotinib, IPASS trial, landmark trial, first one. Then erlotinib based on optimal, Lux Lung 7 afatinib, Archer 1050 dacomitinib, Flora is osimertinib. So we can see that as the generation is going on, the graph is increasing. The outcome parameter in terms of PFS outcome, that is 18.9 months, which is maximum, is seen with the latest generation TKI, that is osimertinib. And if we see in detail about all these drugs, first this chart is shown for the afatinib versus gefitinib. So trial was Lux Lung 7, and important highlighting point in this trial was that all the stable brain metastasis patients were included in this, which were around 16% patient out of all. And if you see the curve, that they are really separating apart in the sense after 1 year or so, that afatinib is showing advantage over and above the gefitinib after this period. On the other hand, if you see Archer 1050, these curves are separating earlier. So this has moved to 6 months down the line. Dacomitinib. So it is showing, in fact, better PFS, and curves are separating earlier also. So so this was about Archer 1050, and third graph is shown by for the Flora trial. That is osimertinib with standard of care. It can be gefitinib or erlotinib. So basically, first generation drug was kept as a control arm in this trial, and osimertinib was the experimental in this trial. And here, we can see that these curves are very beautifully separating from the very early stage, early duration. And stable brain mets are also included in this trial, roughly around 19%. So, and after PFS, if we talk about overall response rate, about LUX-Lung 7, we can see that 70% was the response rate for afatinib, vis-a-vis 56% with the gefitinib. And duration of complete response, duration of response was 91 months, 91% with the afatinib, with this as compared to 87 with the gefitinib. If we talk about Archer 1050, overall response rate was slightly higher, 75%. And complete response was very good, like 5% was there in jacomitinib and 2% of gefitinib. Stable disease was 13%. On the other hand, partial response was in 70% with the decomitinib. And duration of response was also much higher with the decomitinib, that is 14.8 months as compared to 8 months with the gefitinib. On the other hand, if we talk about FLORA trial, overall response rate was best among all, that was 80% as compared to 76% with the comparator arm, which was gefitinib as well as erlotinib. Complete response was seen around 7%, 7 which was 3% in osimertinib. Partial response was 77% in osimertinib, and stable disease was in 17%. On the other hand, comparator has lesser number of all these response rates. So basically, osimertinib has shown highest overall response and median duration of response. So this is the graph which is showing that last third generation drug, which was osimertinib FLORA trial, which have shown as a final analysis, which data cutoff was kept in 2019, and overall survival they have mentioned at 1 year it was 89%, which as compared to 83%. At 2 year, it was again had shown good overall survival, 74%, 59%, and at 3 year it is 54% as compared to 44% with the first generation TKI. So median overall survival was more than 2 years, and osimertinib patients were more likely to be alive at 2nd year and 3rd year landmark, as we can very clearly see from this graph. So this is the first time that any TKI has translated PFS into the significant OS benefit. So if we talk about OS outcome in regard to LUX-Lung 7 and Archer 1050, there is hardly any difference in OS which you can see. First graph is showing this LUX-Lung 7 for afatinib, curves are merging ahead. And Archer 1050, there was some statistical analysis which they have mentioned that it was based on one hypothesis testing. Therefore, OS analysis was doubtful for this Archer 1050. The trial had some hierarchical stratified statistical design, and given that it did not meet the statistical significance in all response rates, so p-value could not be given for OS in this trial particularly. So 28% of patients were still receiving osimertinib at 3 years, which we can see from this bar chart. 28% were alive, and which were 3 times more than patients in the comparator arm. Like on first generation, 9% patients were alive at 3 years. On the other hand, 28% were alive with the osimertinib at 3 years. So another important highlighting point about FLORA trial was that they have included the brain metastasis patient in at baseline setting only, with known or treated CNS metastasis who have received the radiation to the brain. So roughly 116 patients were there in this arm, and without known or treated CNS metastasis were roughly 440. So 2/3 patients roughly were without brain metastasis, 1/3 with the brain metastasis. If we see the compare in two arms, that separation of the curve between first generation and third generation is more or less similar. That osimertinib has shown advantage over and above the first generation drug, even in those patients who have extensive brain metastasis, whether they were treated or stable asymptomatic brain metastasis. So median PFS was 15.2 months with osimertinib as compared to 9.6 with first generation TKI, and without brain metastasis it was even higher, 19.1 months. So another important very aspect, they have come out with the intracranial PFS. how many patients had intracranial progression in the patient's arm which were on osimertinib as well as first generation. So if we talk about first generation standard of care, which was there at that time, it was 13.9%, like 14% patient had CNS progression. On the other hand, at the time of publication of this trial, osimertinib, there were no intracranial progression reached, and this was hazard ratio was quite significant, 0.48 with p-value of 0.014. So if we combine all these three drugs, afatinib, dacomitinib, osimertinib, so what was the response as in regards to CNS response? So Lux-Lung 3-6 baseline asymptomatic brain metastasis were included, and systemic response was assessed. So there was a good response in this trial with the afatinib. Median CNS progression-free survival was 8.2 months. If we talk about Archer 1050, not analyzed because of some statistical flaw. Osimertinib FLORA trial. So there were two outcomes in regard to brain, which we have discussed in previous slides. Systemic, if we see that CNS metastasis, 15.2 months were there. If we talk about intracranial progression-free survival, and not reached as of now. So this was the summary slide of all these three TKIs. Next question comes about the safety profile. Archer 1050, we see a lot of dermatitis, acneiform, diarrhea with dacomitinib, which are more than grade 3 or 4. Sometimes 4% they are maculopapular rash, pustular rash with that dacomitinib. So around 63% patients were reported to have grade 3 to 4 adverse event with dacomitinib. On the other hand, 31% patients had adverse event which were more than grade 3 with afatinib, and only 18% patient in FLORA had more than grade 3 adverse event, and that were diarrhea, which were 2%, decreased appetite 2.5%, fatigue was 1.4%, rash was 1.1%. So rash was down the list in FLORA trial. It was very minimally seen in 1.1%. So if we segregate all these side effects separately, so skin was involved most commonly with the dacomitinib in Archer trial, 14%, least with the osimertinib. Paronychia, which is very troublesome sometimes, we have to use even antibiotic, antifungal because of superadded infection. So with dacomitinib it was much higher, 7%, and least with the osimertinib. Diarrhea is also higher with the dacomitinib and afatinib. Stomatitis is also seen with this second generation TKI, and osimertinib has the least of all these side effects. So in Lux-Lung 7, adverse event leading to dose reduction were more frequent in afatinib. It was roughly around 40%. In Archer, it was roughly around 67%. Dose reduction were required, and in the FLORA, only 5% were requiring the dose reduction because of all these side effects. And quality of parameter, we can see that on the right side, green bars, we can see that global quality of life was improved from baseline in both osimertinib and EGFR TKI comparator group, with no clinical relevant differences between the groups. So if we talk about this quality of life, be it cough, patient presenting with cough, dyspnea, pain in the chest, or whatever complaint he had at the baseline, so it was improved in all scenario. So then after so much options we have, there was a debate that if we use the sequencing, that if we use the first generation or second generation TKI upfront and keep the osimertinib third generation for the usage of on the second as a second line, so we can achieve the better outcome as compared to if you use the osimertinib upfront, which is a good PFS roughly around 19 months. So the answer to that will be shown by this numerical data, that if we suppose that 10 patients had EGFR mutant positive who we have given first generation, second generation TKI, and out of this usually 73 to 77% will receive the second line therapy, because rest patients usually die during the first line, or they go for the palliative care. Maybe because no T790M test was available over that time, or they were not keen for that. 60 to 75% patient out of those who were receiving this second line treatment were able to achieve the valid T790M tests, on what basis we can give the osimertinib. So only 50% patient were able to achieve this test positive T790M and able to achieve the osimertinib. So 7 out of 10 patients who started on second generation TKI will not be able to receive osimertinib in the second line. So this is good chunk of patients were not able to receive the best drug available as of now. So, and it was not possible to predict who is going to develop the T790M resistance in due course of time. So therefore, I think the bottom line was that it is always advisable to use the osimertinib as the first line setting rather than to keep it as the second line. So if we talk about access to the second line therapy in various trials, first trial IPASS for gefitinib, 76% patients were able to achieve the second line therapy. So more or less all the trial are saying the same story, roughly varying from 50 to 75% were able to go for the second line treatment. So approximately 1/3 patient were not going for second line treatment because of whatsoever reason which we have discussed just now. So now real world evidence of T790M after afatinib, there was a Japanese study that which showed that 43% of 37 patients acquired T790M after afatinib. In Taiwan also 48% had acquired T790M. So that was a story about the acquiring T790M. So less than 50% patient on afatinib were acquiring the T790M mutation later on, so that we could use the osimertinib. So regarding sequencing, this is not a optimal clinical care with the sequencing. So we are not smart enough to figure out who will get the T790M. So as of now, osimertinib remains the standard of care as the first line therapy, if as far as possible. So there are some uncontrollable factors also in the sequencing. Toxicity to the drugs, occurrence of T790M, sites of progression, concurrent morbidity, and patient choice. After discussing all these things, so they have come up with the real world studies with first line osimertinib. They were first study Flower trial, Flower study, then OssiFact, then one more Mykonos. I think one of my next speaker will be talking about all this experience, all this data about the real world evidence of osimertinib in EGFR mutant setting. If we talk about NCCN guideline, which we are all used to see, that EGFR exon 19 deletion or L85R mutation is there. So EGFR discovered upfront, then osimertinib is a category 1, although and which is the preferred one also. Although all the TKI has been given category 1 recommendation. On progression, definitely we are free to choose any other options. Osimertinib maintains a strong recommendation for first line setting in stage 4 NSCLC, and there were some moderate recommendation which have come up with the doublet. If we combine data is emerging, gefitinib with the doublet chemotherapy or doublet chemotherapy, or even combining with the erlotinib combining with the VEGF inhibitor like ramucirumab or bevacizumab. So many oncologists are using this combination also. I think this is cheaper than using the osimertinib monotherapy. There maybe that is one of the reasons to use erlotinib with ramucirumab with good outcome. So summarize my slides. Osimertinib is the only EGFR TKI which has demonstrated a clinically and statistically significant improvement in overall survival. Median OS benefit of greater than 3 years. It sets a new benchmark for osimertinib and provides a window of opportunity for management of patient with difficult to treat stage 4 NSCLC with this particular sensitizing mutation. So FLORA is the first time EGFR TKI that has translated PFS into the OS benefit, and nearly 30% patient, 1/3 patient were there on osimertinib at 3 years, and this is the only drug which can be given to the patient with brain metastasis as well as T790M mutation with least toxic side effect, which we have discussed just now. And this data confirmed osimertinib as the first line standard of care in metastatic EGFR mutant NSCLC patients. So thank you. I will stop here for my presentation. So now for this CME, we can move on the next talk, which is on, as I said, real world evidence of osimertinib as a standard of care in management of EGFR mutant NSCLC patient. And to deliver this talk, I would invite Dr. AP Dubey. He is Senior Consultant Medical Oncology from Shanti Mukund Hospital, Delhi. Dr. Dubey, over to you.
Good evening, everyone. Thank you, Denny sir and Astra, for giving me this opportunity to speak on this very interesting topic, that is real-world evidence of osimertinib as standard of care in management of EGFR mutated non-small cell lung cancer. As Denny sir has already introduced, that lung cancer is the most commonly diagnosed malignancy, accounting for around more than 11% of all newly diagnosed cancer. And with the understanding of the molecular pathways which drive malignancy, it has led to the evolution of targeted therapy in the patient who actually carry driver mutations. So the most commonly diagnosed or detected driver mutations are EGFR mutations. And with the advent of the anti-EGFR TKIs, the outcomes in such patients have dramatically increased. So we have many generations of EGFR TKI, first generation, second generation, and third generation. And osimertinib, which is an irreversible third generation EGFR TKI, has already demonstrated a clinically meaningful improvement in median progression-free survival as compared to the first generation TKI in phase 3 randomized FLORA trial. Apart from this, osimertinib is the first EGFR anti-EGFR TKI which has shown the meaningful improvement of overall survival, 38.6 versus 31.8 months, with a hazard ratio of 0.80 in the FLORA study in patients with EGFR mutated non-small cell lung cancer. So this is the FLORA study, the final overall survival analysis. So the schema was already being discussed by Denny sir, that patients with locally advanced or unresectable or metastatic non-small cell lung cancer were stratified and randomized to either osimertinib or the first generation TKI. PFS was the first endpoint and the OS was the secondary endpoint. Baseline characteristics were almost matching among the comparator as well as the interventional arm. And you can see the very beautiful separation of Kaplan-Meier curves. Osimertinib significantly improving the progression-free survival. And on the right side, you are seeing the forest plot. Almost every subset of patient, irrespective of their age, sex, ethnicity, smoking history, presence or absence of CNS metastasis, performance status, type of EGFR mutations has led to the achievement of outcomes in or the better achievement of outcomes in the osimertinib arm as compared to the first generation TKI. So something which has been different in osimertinib is the overall survival benefit too. Osimertinib, as you can see, that has led to the improvement in the or meaningful or you can say significant improvement in the overall survival as compared to first generation TKI. At the 36 months, the overall survival in osimertinib arm was 54% as compared to 44%. So there is absolute difference of 10% in these two arms. So conclusion that that randomized phase 3 study FLORA has actually statistically significant outcomes in both progression-free survival as well as overall survival when the patients were offered osimertinib as compared to the first generation TKI. And after 3 years, 28% of the patient in the osimertinib arms and the 9% of the patient in the comparator first generation EGFR TKI arm remain on the first line study treatment. So 3 times as in the first generation TKI, patients were on the osimertinib. So osimertinib presented a favorable and consistent toxicity profile despite the long exposure to the drug. So that made osimertinib the preferred therapy, category 1, in patients with EGFR mutated non-small cell advanced lung cancer. That we can see the NCCN guidelines too. So as we know that randomized controlled trials are quite strict and the inclusion criteria is quite strict, and that does not mirror image the real world clinical practice. So real world studies are very well important and paramount for clinical decision making, as it makes the utilization of the drug in the real world practice patients, and thus brings the confidence in decision making with the physicians. So these are the three studies: FLOWER study, OSIFACT, and Mykonos study. So this one is FLOWER study, the first line osimertinib in patients with EGFR mutant advanced non-small cell lung cancer. So the background was very clear that the FLORA study has led to the significant improvement in median PFS as well as overall survival in patients who were offered osimertinib as compared to the first generation TKI. But only less than 5% of the patients actually received treatment in randomized controlled trial. And these randomized controlled trials tend to exclude patients who are actually are not meeting the strict criteria of those trials. So raising the issue of the real representativeness of the real world study, or the real world patients, or real clinical practice patients. So real world data therefore becomes a very useful tool to assess the unique insights in routine oncology practice for the post-marketing setting and a confident decision making. So these are the baseline characteristics. You can see the median age was 68 years, and a female constituted 65% of the patient, whereas male 35%. Brain metastasis were present in 30%. That is, brain metastasis patients are actually symptomatic patients are actually excluded in the randomized control study. In many studies, brain metastasis patients are generally excluded. And exon 19 EGFR mutant were accounting for 50% of the patients. And you can see that most of the patients were stage 4, and only 5% of the patients were having stage 3 unresectable disease. 87% of the patients were having ECOG PS1 status. And these are the inclusion criteria, and exclusion criteria was only that when the patient who actually received study drug in the clinical trials. So the primary endpoint was median time to discontinuation, a measure from the osimertinib start to the discontinuation because of the any cause, whereas the secondary endpoint was the median PFS and median OS, objective or overall response rate, and disease control rate. So this primary assessment, you can see that the time to treatment discontinuation median is 25.3 months in the group of patients, and in patients who were not symptomatic at the onset of the disease when the treatment was started or the initiated, then the time to discontinuation, the median is not reached, whereas the patient who was symptomatic at the initiation of the osimertinib, the time to discontinuation was 18.8 months. And the patient with less than 3 metastatic site, time to discontinuation, that is TTD, is not, median is not reached, whereas patient with 3 or more metastatic site, the median time to discontinuation was 21.4 months. So primary assessment of the effectiveness, the patient with the poor PS, comorbidities, and rare EGFR mutations and active brain metastasis, which are actually generally excluded from the randomized controlled trials, were included in this real world data, and outcomes were similar to whatever published data we have seen in the randomized controlled trial, thus adding consistency and bringing the confidence in the drug. No differences in progression-free survival, time to discontinuation, and overall survival were noted in elderly patient or patient with comorbidity and less common or uncommon EGFR mutations. So time to discontinuation was the unique primary endpoint which was taken in this particular study, and they considered it as a suitable endpoint to evaluate the treatment outcomes in pragmatic real-world trials. And it was longer than the post-progression outcome analysis of FLORA trial, that is 20.8 months, probably due to study population unfit for further therapy or different therapy for oligoprogressiveness in the randomized control study. And better time to treatment, time to discontinuation was seen in patients who were having less than 3 sites of metastasis rather than patients with 3 or more sites of metastasis. So this is the univariate and the multivariate analysis, and it was been found that the patients, the negative predictors of prognosis are the patients who are having more than 3 sites of 3 or more than 3 sites of metastasis at presentation, patients who are having brain metastasis at presentation, and patients who are symptomatic at presentation. These 3 were found to have poor prognostic factors in patients with advanced non-small cell lung cancer with EGFR mutations. So after median follow of 12.3 months, the median PFS was 18.9 months, and that is almost matching the FLORA study. Median OS was not reached at the time of data cutoff, and the CR rate was 0, but partial responses were 73%, and stable disease was seen in around 30%, and progression was seen only in less than 5% of the patient. So this is primary assessment, progression-free survival, median 18.9, perfectly matching the randomized controlled trial study, despite including patients with poor PS with active brain metastasis and patients with comorbidities, and patients with progression-free survival where no brain metastasis were present, then the median was not reached, whereas patients with brain metastasis present at onset, the progression-free survival median was 13.3 months, and patients where the symptoms were present at the onset, the progression-free survival was median 15.5 months, whereas there were patients who were not symptomatic, the median was not reached. So this we have already discussed. So, so this real-world study actually help us in decision making, as they include the patients of real clinical practice, what we encounter on our day-to-day practice, and the safety profile also. There were no new safety signals were experienced with this particular osimertinib drug. So now this is the OC fact. That is, you can see the second real-world study that osimertinib as first-line treatment for advanced EGFR mutation positive non-small cell lung cancer in real-world setting. So the background is same as we have seen, because osimertinib has proven its point or effectiveness in randomized control study. So they wanted to learn its efficacy in real-world study and also the safety data. So inclusion criteria were advanced EGFR mutated non-small cell lung cancer, and exclusion were patients who are undergoing either concurrent radiotherapy or patients with who are undergoing post-operative adjuvant chemotherapy or receiving osimertinib as second-line treatment. So these are the baseline characteristics. As you can see that there are patients of all age groups less than 75 years accounted for 60%, whereas more than 75, around 37. Females were more, around 65%, and there were 40% of patients who were smokers some of the other time. 98% were the adenocarcinoma. And if you see, exon 19 del was 50% and L858R was 45%. So study endpoint primary was PFS here, and secondary was OS, overall survival and time to treatment failure, response rate. So you can see the median PFS with this drug in this real-world study is 20.5 months. Again, it's matching, or numerically you can see the higher than the randomized control study. And PFS event occur in 182 of the 538 patients, and other parameters which are actually significantly associated with the PFS, or because in multivariate analysis, what has happened that the estimated hazard ratio of the risk factors for progression-free survival in multivariate analysis, investigating an association between the clinical factors and the progression-free survival was noted that, and the parameters which were significantly associated with the decremental PFS were male gender, malignant diffusion, liver metastasis, and advanced unresectable disease. With respect to the PDL1 expression, median PFS was not reachable in patient with TPS value less than 1%, 14.7 with TPS less than 49%, 11.1 with TPS 50%. So this is the efficacy analysis in the multiple clinical factors, and this multivariate analysis actually investigated the association of PFS between the clinical factors, and it was found that the clinical factors like male sex, malignant diffusion, and the advanced unresectable disease, liver metastasis, and mutation type and PDL1 expression were actually associated with the progression-free survival. With the respect to mutation type, if you see, then exon 19 del, if you consider to be the standard mutation type, then L858R and uncommon mutations were associated with the decremental PFS. And with the respect of PDL1, then the maximum benefit was achieved by less than 1%. If it considered to be standard, then the higher PDL1 expression was considered to be having the decremental PFS benefit. So this is again the safety data. Then you can see that the adverse events of special interest, the pneumonitis of all grade was seen in around 10 to 12% of the patient, but grade 3 to 4 pneumonitis was seen in less than 5% of the patient. Same goes for hematological or non-hematological toxicity. Grade 3 to 4 toxicity was seen in less than 5% of the patient. Q2 interval was though prolonged in less than 5% of the patient, but grade 3 QT interval prolonged was seen in only 1% of the patients. So in conclusion, the objective response rate was 76.2, disease control rate was 94.1, and PFS was better with osimertinib than with the conventional EGFR TKI, irrespective of PDL1 expression. Median time to treatment failure was 19.1 months. The median time to start of the treatment and the onset of adverse event was 56 days. And pneumonitis of all grade occurs in around 12.8, but the grade 3 or higher was seen in less than 5% of the patient. PFS after first line osimertinib treatment in real world practice was favorable, and it was matching the randomized control trial. This is the last, and I'll be taking 2-3 more minutes. Real world study of patient with EGFR mutated, locally advanced or metastatic non-small cell lung cancer treated with first line osimertinib. Again, the background is same because osimertinib has shown its efficacy in the FLORA study, and it is osimertinib is a third generation irreversible oral EGFR TKI that potentially and selectively bind both EGFR TKI sensitizing and EGFR T790M mutation. And FLORA study has shown significant improvement in PFS as well as significant and meaningful improvement in OS. So that remains the need to evaluate its real world efficacy in the disease characteristics and the clinical outcomes. So this is the study's design, and only the interim analysis has been done. Because interim analysis data was the follow-up period is planned till 2023, and interim sub-analysis data was collected till June 30, 2020. So the patient identification date was April 1, 2018, and the end date was March 31, 2020, and the interim analysis was done on 30th June of 2020. As I have already told, that study is still undergoing. So what was their unique point, what they have taken is that real world time to treatment discontinuation and real world time to next treatment or death. And the Kaplan-Meier curves were being generated using these two TT and TD and TTD. And unadjusted and adjusted Cox proportional hazard model was also used to assess the association between baseline covariates and the clinical outcomes. So these are the baseline characteristics. All age, sex, race, and regional patients were taken. And these are the baseline characteristics of the tumor. And you can see that around 80% of 80 patients were having liver metastasis, accounting for around 15%. And the brain metastasis was present in around up to 35%. 1/3 of the patient had brain metastasis at the onset of the treatment. All were EGFR mutated positive, and exon 19 and del was in 51% of the patient, and the next was L858R. And uncommon mutations were in 4%, and only uncommon was in 9.5%. So the interim analysis was done on in 2020. So 318 patients remained on first line osimertinib therapy, means 58% remained on first line osimertinib at interim analysis, and whereas 18.8% received second line treatment, whereas around 18% patient died on first line treatment and 4.7% discontinued first line treatment. You can see that around 60% patients still remained on osimertinib at the first interim analysis, and you can see the median follow-up time was 9.6 months, and real world time to next treatment or death was around 18 months. That's also matching the real world study. And if you see now, the multivariate analysis among the clinical factors were done to predict the poor prognostic factors. It was seen that the poor prognostic factors were staged at the initial diagnosis of non-small cell lung cancer, smoking status, and poor performance status in the form of Charlson Comorbidity Index, EGFR mutation type. When exon 19 del was achieved the maximum benefit, other common and uncommon mutations were associated with decremental benefit, and the patient with more metastatic sites were associated with decremental PFS benefit. So as I've already told, real world time to treatment discontinuation was 17.2 months. And this we have discussed. So the take home messages at the end that all these three studies have actually provided us the confidence about the drug osimertinib, because not only in randomized control study, but in at least 3 real-world studies, osimertinib has shown its efficacy despite including the patients in real-world practice which are associated with poor performance status, more of comorbidities, and also the brain metastasis. We can see that in real-world studies, the brain metastasis is seen in around 1/3 to around 3/5 of the patients. So, and it has the different unique endpoint for taken in real-world studies, PFS, TT, NTD, and time to treatment failure. And they all actually supported the effectiveness of the osimertinib in this real-world population. Thank you. Thanks for the patient listening.
Thank you, Dr. Dubey, for enlightening us about real-world evidence. Although we have been using this drug since last maybe 5-7 years, so but still we have very good data about real-world also. So next to move on, we have panel discussion about the management of advanced NSCLC with EGFR mutation positivity. So although this topic looks simple, but yeah, there are a lot of advancement which is happening up. And to moderate this session, I would invite Dr. Shyam Agarwal. I'm sure there are so many highlighting points which will come up in this panel discussion. Dr. Shyam Agarwal, sir, he is the senior consultant medical oncologist, Sir Gangaram Hospital. So over to Dr. Shyam.
Yeah, thanks,
Sir,
Danny, for this opportunity. Can you introduce the panelists and slides
sir.
can be shared?
So I would invite the panelist, Dr. Salab Arora. He is from Cygnus Ujala Hospital, Haldwani. Dr. Salab, are you there?
Yes, sir, I'm here.
Dr. Salab is there. Dr. Amit Sherawat, Senior Consultant Medical Oncology, AIMS, Rishikesh. Dr. Amit?
Sir,
Dr. Amit Sherawat.
Sir, Dr. Amit sir is not here. Unka message aaya hai. Something urgent came up.
Okay. So Dr. Ankit Batra, he is from I think Himalayan Institute, AIMS, Dehradun. Dr. Ankit Batra.
Good evening, sir. I'm here, sir.
Yeah. Dr. Ankit is also there. And Jyoti Anand, Dr. Jyoti Anand from Yashoda Hospital.
Ma'am,
Delhi, Gajwal.
Sir, Jyoti Anand, ma'am, is just logging in just 30 seconds.
Okay. So, sir, there are 3 panelists, Dr. Salab Arora, Dr. Ankit, and Dr. Jyoti Anand.
Thank you very much, Danny. So I think, can the organizers share the slides? So I think you heard the data on EGFR mutated non-small cell lung cancer, especially osimertinib is the focus here. So I think we're running a little behind schedule, but then we'll try to cover up by discussing a few case scenarios like EGFR mutation with high PD-L1, oligoprogression, and patients with brain mets. So can I have the next slide? Okay, so this is a 65-year-old male patient, non-smoker. It has cough and some pleuritic chest pain for 1 month. And on the CT chest, there is a 5.5 centimeter tumor invading pleura. There is left pleural thickening and effusion. Biopsy reveals adenocarcinoma, TTF1 positive. And the PDL1 is 95%. And if you look at the EGFR, there is exon 19 deletion. Next slide. So the question is, what routine molecular markers do you look for in NSCLC patient? Dr. Shalabh, you would like to take this?
Sure, sir. So the routine molecular markers we're looking at includes EGFR. Then I would also look at ALK, ROS, and compulsorily probably now also include BRAF and RAS, since now we have some drugs available for those as well.
So do you routinely do PDL1 as well?
Yes, sir. We do obviously include PDL1. I think I left it out on purpose because of the next statement, I thought. PDL1 definitely, sir. We also do that by IHC at the baseline at the time of diagnosis itself.
Is Dr. Jyoti there? Or we have Dr. Amit, I think he's joined.
No, sir, Amit sir is not here.
So who's the third panelist?
Jyoti ma'am is there. She will be logging in soon, sir, any minute.
Okay. So you know, in this patient who has high PDL1, so I think the report takes how much time, Dr. Amit? Or Dr. Shalabh is there?
Good evening,
right?
sir.
Yeah.
Yeah,
So what
Dr.
is the turnaround time for these reports in your lab, which includes various molecular markers and PDL1?
So I'm Dr. Ankit here, sir. PDL1
yeah,
I see we are usually getting in 4 to 5 days. In 4 to 5 days. And EGFR, if we are sending by PCR, that also we are getting in 4 days. But NGS, we are taking at least 2 weeks.
So you are asking for EGFR separately upfront?
So no, sir, it depends on the patient profile. If we have a patient who can afford all the drugs, all the targetable mutations, that we are planning to send the NGS. But if the patient profile is not like that, then we are sending only EGFR, PCR plus ALK-ROS.
Right. So I think the PDL1 report is an IHC report which comes in early. So if you see this PDL1 coming at 90% and the patient is symptomatic, so will you start the therapy or will you wait?
So if the patient is symptomatic, we'll start with chemotherapy and we'll wait for the NGS or the EGFR report and not start with immunotherapy.
Okay, so you will, you know, even if the patient is symptomatic and high PDL1, you will wait for the EGFR or the NGS report.
Definitely, sir.
Dr. Shalabh, you agree to this?
Yes, sir. I agree with this. That if the patient, I would still wait for the EGFR report in most cases.
So I think there is a consensus. If Dr. Jyoti is there, she can also make a comment if she is logged in.
Yes, sir. Good evening. So I would also wait for EGFR report, and I will not suggest immunotherapy. I will rather start with the chemotherapy if the patient is symptomatic because of the burden of the disease.
So I think there is fair consensus that we should not be jumping on to starting the immune checkpoint inhibitor, you know, unless you have the exclusion for the EGFR, ALK, and ROS at least. Can we have the next slide? So I think we have covered this point. I mean, the EGFR and PDL1. So out of both, you have to prioritize for EGFR because of the better responses. Next slide. And actually giving the immune checkpoint inhibitor can be hazardous to these patients. So and any thoughts on the use of immunotherapy in EGFR or other you know, targeted mutations? Shalabh?
Sir, I think from whatever we know from retrospective data, apart from the BRAF mutated, the others don't respond very well to immune checkpoint inhibitors. Even in BRAF, I think the response rates were not very significant, close to 30%, if I remember right. So I would definitely bank more on the molecular targets rather than going with PDL1 targeted therapy.
Yeah, Ankit, your thoughts?
Yes, sir, I agree with Dr. Shalabh. And maybe PDL immunotherapy we can use in later lines once patient has exhausted all the targeted therapies.
Right. I mean, okay, you've given the chemo first cycle, and then after 2.5 weeks, you get tumor insufficient, and PDL1 is 90%, and you've given first cycle of chemo. So what are you going to do then? Because PDL1 is high and you don't have the information on EGFR.
So at that time, sir, I will counsel the patient for a if I would go for a liquid biopsy and would still wait and hold on my horses for using immunotherapy.
Okay, so you will ask for a liquid biopsy. Dr. Shalabh, you agree?
Yes, sir. I would, if there's no more tumor tissue to be had, then I would go for liquid biopsy in that case.
Dr. Jyoti, are you doing liquid biopsy in patients where there is insufficient tumor tissue?
Yes, sir. If repeat biopsy is a challenge, then liquid biopsy can be tried.
And you will not give immunotherapy?
No, sir.
So the chemotherapy would continue?
Yes, yes, sir. Chemotherapy will continue.
Okay, so I think people are quite clear in their approach here. Next slide, please. Okay, so now this is the outcome of patients with high PDL1. As you can see, if the PDL1 is less than 1%, you get the maximum sort of outcome as compared to okay. So I think there's some issue on slides here. Can we go to the previous slide? Previous slide, please. Previous slide. Okay. So I think the point is, Ankit, so what is your first line therapy for an EGFR mutated patient?
So basically, sir, if it's a sensitizing mutation, I would offer osimertinib, and especially with patients with brain mets. But if our patient profile is like that, they are not able to afford or not coming under any schemes, then we are preferring platinum-based chemotherapy with gefitinib, combination of TKI and chemotherapy. But preference is always osimertinib.
Okay. So if the patient cannot afford, then you're talking about chemo and gefitinib.
Yes.
Dr. Shalabh?
Sir, I agree with the first part of this. Osimertinib is the preferred modality. Again, if there's cost issue, then I would go with single agent TKI. In my practice, I don't combine TKI with chemotherapy in the first line because of the concerns about toxicity.
So what TKI do you use? First generation or second generation?
So most generation, first generation. Erlotinib is what I go to. And then I save the chemotherapy for a later time at progression.
So Dr. Jyoti, your call on the first line therapy for DEL19 mutation advanced lung cancer?
If the patient can afford, yes, definitely take osimertinib. But if patient cannot afford single agent TKI, I would prefer, and I would try using second generation TKIs rather than first generation TKIs.
Right. So this is very interesting. Of course, everybody's first line is osimertinib, but then if the patient cannot afford osimertinib, there are three physicians offering three different options: first line, first generation TKI, second generation TKI, and a combination of chemotherapy and gefitinib. So I think this is an interesting area because you've got so many drugs now to to offer to a given patient. So this was not the case maybe 20 years back. So this is very interesting, which we can. So what do you do in a patient who has been given first or second generation TKI and the patient has progressed? So Dr. Shalabh, what do you do?
So then I would definitely discuss at progression the option of osimertinib. Because as we know, the most common mechanism is T790M. If possible, then we can profile the tumor. If not, then we could go to osimertinib straight away in second line. And
so you are suggesting that without doing any further investigation, we can switch to osimertinib?
So definitely, I would, like I said, I would prefer profiling, tumor profiling again, looking at the resistance.
A patient doesn't want patient is not willing for any tissue, biopsy in the after progression.
Then, sir, I would then probably chemo would be my go-to option in such patient, because
okay, Dr. Ankit, if the patient is not willing for a biopsy of the tumor after progression on first generation or second generation TKI, what would you do?
So at the time of progression, we are not offering biopsy from the tissue, sir. We are directly going on to liquid biopsy for T790M mutation. And if that is positive, we would prefer osimertinib. If that
so what is that liquid biopsy test?
So liquid biopsy for this thing T790.
Right. So it is not. I mean, it's basically if you were to do the ddPCR, which is available in several labs, so which is not expensive and it is quite effective. Dr. Jyoti, your thoughts on doing the ddPCR liquid biopsy after progression on first or second generation TKI?
So if patient is willing, then normal biopsy, otherwise liquid biopsy can be offered to look for T790M mutation, and so that we can offer the patient the good effects of osimertinib.
So in the absence of the liquid biopsy and the tissue biopsy, will you switch from first generation to osimertinib?
No, sir.
Okay, so if that is not available, then the choice would be chemotherapy, right?
Yes, sir.
Yeah. So Dr. Ankit, you agree to this?
I think it's a very difficult call to take on that, because as Dr. Shalabh has told that it's 50 to 60% patient have that mutation.
Right,
and
right.
If you don't have option, I will, and logistic is not the issue, I will definitely try with osimertinib with a close follow. And if the patient is responding, will continue. Not responding, then switch to chemotherapy.
I mean, if the patient is on first generation TKI or a second generation TKI, and she develops CNS metastasis, which is not amenable to SBRT. So Ankit, what is your thought?
So not amenable to local therapy, then definitely like SBRT, then definitely we'll plan whole brain RT. And if there is no extracranial progression, would like to continue TKI. If there is extracranial as well, then we'd like to change the therapy, systemic
So
therapy.
my question is pointed in the sense that, will you like to switch from first generation to osimertinib for brain?
Definitely, sir. Osimertinib has clearly shown a better response rate in brain metastasis, better CNS penetration. So that would always be a much better option as compared to other generations of TKI.
No, so I mean, you don't have the availability of the T790M. So in the absence of that, will you switch to third generation osimertinib?
Maybe, sir, I will counsel the patient. Logistic is not an issue. Then we'll take a shared informed decision with the patient. But my preference would be definitely osimertinib.
Yeah, Shalabh, you agree with this?
So I think if there's CNS progression that's not amenable to SBRT, there's no doubt osimertinib should be the next preferred agent.
Right. Dr. Jyoti, you also agree for the CNS disease?
Yes, sir. I think osimertinib has got good penetration and it should be preferred.
So I think there is a reasonable consensus that if somebody progresses in the brain, so patients should be offered osimertinib and local therapy as well. if depending upon the location of the tumor and the number of tumors in the brain. So the same question can arise, if somebody is on erlotinib and has an oligoprogression. So, and that's amenable to SBRT. So would you just continue with erlotinib or will you switch to osimertinib? Ankit?
Sir, in that case, would like to give stereotactic radiation and continue with erlotinib.
Right. Shalabh?
Sir, I totally agree with that, with the plan better front.
So here you I mean, if the patient is willing to give you a biopsy and you find T790M, will you switch and give radiation?
Sir, now that it's oligoprogression and patient has only one site, I know there's probably no clear answer to this, but I would preserve osimertinib for a later time point.
Dr. Jyoti, patient now has progressed with T790M and we've done the SBRT. Will you switch or will you continue with the old one?
I think, sir, I agree with other panelists that we should reserve the osimertinib for later lines, and patient has just oligoprogression. We have treated the patient for locally for oligoprogression. We'll continue with erlotinib and will reserve osimertinib for later lines.
Great. So I think we have a great consensus here that you like to preserve the drug, even if there is T790M, there is an oligoprogression. So my final question is, in a patient who is on osimertinib and he has progressed at multiple sites, so what do we do with that patient, Shalabh?
Sir, progression on osimertinib, I don't think there's very good data in this setting. I would, if the patient is symptomatic, I would repeat a tumor profiling with NGS to look for any other mutations that might have developed. But in the meantime, patient is symptomatic, start with chemotherapy.
And what would that be?
Sir, a pemetrexed and a platinum combination in most cases.
Do you use immune checkpoint inhibitors there in combination?
No, sir. I don't have on progression with EGFR sensitizing mutation. I don't think immune checkpoint should be included at that.
Right. So Ankit, your thoughts?
So if we have any sort of clinical trial running in that setting, I would like to put that patient in that clinical trial. Otherwise, if we don't have any clinical trial, then would like to start with chemotherapy, and immunotherapy can be plus minus as per the profile, but the data is not very strong or good for in this setting.
Dr. Jyoti, your thoughts? Anybody in favor of ABCP protocol?
Do they have data that the patients who progressed on EGFR TKIs, they benefited with the use of ABCP combination? But I think it all depends upon the performance status of the patient and what type of chemotherapy regime should be used. It also depends upon the performance status of the patient, whether weekly therapy has to be followed or we can give 3 weekly pemetrexed and platinum combination. So ABCP, if patient can afford, I think according to performance status, yes, it can be tried. Otherwise, we can wait for an NGS report from re-biopsy sample, and then we can add on immunotherapy.
Right. So I think fair enough. One can look in for tissue and do the NGS and look for escape mechanisms like MET and others. And if not, people want to give chemotherapy with or without immunotherapy. So I think that's would be a take-home kind of a message. So I think we've covered quite a few on EGFR mutation, first line, subsequent line, oligometastasis. So I think with this we can close this session. Dr. Danny, is that okay? I mean, are you satisfied with or you have anybody has any questions? With the panelists are here to answer. So are the organizers there?
Yes, sir. So I think you have covered most of the point. Only thing is that I think erlotinib plus ramucirumab data is also there to use like where patient is not affording to osimertinib. I think I'm not sure about that usage. Have you used, sir, that erlotinib plus ramucirumab?
Not yet. So I think the data is building up. There is some,
many people are using it, but I'm not sure about the data about this combination.
Shalabh, your thoughts on the Ramucirumab data?
Sir, again, I haven't used it. I am aware that this is a combination that has been explored, but no personal experience using it.
So, sir, would anybody like to use that in any mutation apart from L858R, like exon 19, or because data is good enough for exon 21 L858R, but any comments on like using in exon 19?
Yeah, Jyoti.
I have not used it in this regime.
So I think the experience is quite limited at this point in time, at least with us. So mainly meant for, I guess, non-deletion 19 EGFR mutated samples, that is L858R. So I think that answers your question, Denny.
Yes, sir. Yeah, clearly. Thank you.
So I think with this, thank you very much for inviting us to this program and making us a part of your, agenda. Thank you very much.
Thank you.
Thank you, sir. Thank you all the panelists for bringing out all these clinically relevant points very clearly, which we are facing in day-to-day routine practice. So thank you all of you. Now to move on, our last this talk that is on chemotherapy for a change, that is like role of novel forms of docetaxel in the treatment of lung cancer. So to speak on this topic, I would call Dr. Manish Sharma. He is a consultant, senior consultant at RGCI Niti Bagh branch. Dr. Manish.
Yes, sir. Good evening. Thank you so much for inviting me. I'm not able to share my screen, sir.
So anyone can share on their side? Yeah, organizer. Mahima?
Now, sir, now you can share your screen.
Yeah.
Thank you so much, sir, for inviting me here. And I will be speaking on the novel formulations of taxanes. We know frequently taxanes, which are conventional taxane, frequently causes plenty of adverse events like allergic reactions and sometimes bronchospasm also. So we'll be speaking on the challenges with conventional, challenges with conventional taxanes. What is the solution for that? NanoEquilipt technology presented by Intas, and NanoEquilipt formulations in various cancers. We will be speaking on the various clinical trials, the data which has been presented to DCGI, and the data for FDA. The dosing and efficacy of NDLS, that is newer preparation of docetaxel in non-small cell lung cancer. So this is a well-known fact that polysorbate 80, which we use in conventional docetaxel, it causes hypersensitivity reactions. And approximately 30% patients who do not receive pre-medication, they develop hypersensitivity reaction. And despite giving adequate anti-allergic treatment with 2 days of dexamethasone and ranitidine, 8 to 13% of the patients, they still develop hypersensitivity reaction, which is a huge number. And this is Event Alert. This is a retrospective study performed in United States and Japan. It was done on those patients who died because of some kind of hypersensitivity reaction. So 3 patients here, as you can see here in this United States retrospective analysis, and 20% here in Japanese study, they died. And the important thing about these patients are that 100% of them received pre-medication. So giving pre-medication before conventional docetaxel does not prevent fatalities also. Even if the patient have been adequately pre-medicated, the patient may die of this adverse event. And this has led FDA to issue a black box warning against docetaxel in the package insert. Apart from that, infectious disease is also common because of hyperglycemia as we use dexamethasone for pre-medication and post-medication in conventional docetaxel, and infectious episodes, grade 2 and grade 3 because of neutropenia and immunosuppression due to the conventional docetaxel, which is because of the prophylactic steroids. So this docetaxel associated candidiasis is also one of the important adverse event which the Society of Oncology and Hematology this has asked to make a package insert in the docetaxel associated candidiasis for these patients. So this has been recommended that the CDSO should direct the manufacturer to include docetaxel induced associated candidiasis as one of the adverse events. And the entire set come with the novel formulation, which is nanoEquilip technology. And basically, this is a lipid-based drug. The outer portion of which is hydrophilic and inner portion is hydrophobic. And in this layer is a docetaxel drug. So this uses a naturally occurring, generally regarded as safe lipid excipients, which is soil phosphatidylcholine and sodium cholesterol sulfate. So these are basically generally regarded as safe lipid excipients which are used in this lipid-based solution, which eliminates 2-in-80 or chromophore. There is no use of ethanol in the preparation of this drug, and hence it leads to less of amount of grade 3 or 4 hypersensitivity reactions, and almost no need for steroid pre-medication for our patients. So this is a newer technology. So what is the difference between conventional and nanoEquilip formulation? So on the left-hand side, we can see the limitations of the conventional Texin formulations. On the right-hand side, there is a solution which leads to the less of the toxicity for our patients. So there is the complete aqueous-based solution which eliminates polysorbate 80 and chromophore used for the solubilization. The problem with the leaching of the plasticizer from PVC bags and IV set, which is present with the conventional Texin formulation, is no longer present with nanoEquilip formulations. There is no grade 3 or 4 hypersensitivity reaction in this formulation. There is no use of steroids, and hence the steroid-induced side effects, they are pretty low. There is also a lesser amount of, although the lesser amount of data is there, but it suggests that there is low concern of neurotoxicity for these patients who receive NDLS. So it has got optimum molecular size as well, 100 nanometer, which because of which it is able to penetrate into the tumor tissue from the leaky vasculature of the cancer cells, and it gets accumulated in the cancer tissue very effectively as compared to the docetaxel conventional formulation. This is pharmacokinetic comparison of Texotere versus docetaxel technology formulation, and you can see that these are pretty comparable, but even more concentration max, Cmax, and AUC 0 to infinity is achieved in those patients who receive docetaxel NDLS preparation. So you can see that Cmax in nanogram per ml is 5033 versus 7029 in the NDLS population. And similarly, area under curve, which shows us the efficacy of the drug, is also more in docetaxel preparation. T-half of both the drugs is almost similar. And you can see this PK profile of the NDLS. It is higher systemic availability of docetaxel in plasma compartment as compared to the conventional Texotere formulation. So coming on to the, after this basic information about docetaxel technology, we come to the randomized clinical trial which have been done using this formulation. So this is the efficacy study presented in Clinical Breast Cancer Journal in 2014. Advanced metastatic CA breast who have failed on prior chemotherapy. These patients, they were randomized in 2:1 fashion to Texotere, which is standard of care, versus NDLS, the newer preparation by Intas. Total of 6 cycles every 21 days. Dose was similar, that is 75 milligram per meter square. The primary endpoint was objective response rate as measured by RECIST-1 clinical criteria. And you can see that the response rates in the docetaxel preparation were more, complete responses were more, and the total disease control rate and overall response rate, they were more in patients who had received docetaxel. So it was somewhere around 35.5% versus 26.3% in the conventional docetaxel. And coming on to the adverse grade event, they were almost similar. Fewer more neutropenic events in NDLS preparation, while the febrile neutropenia which is of the concern, is almost similar in both the population. Similarly, there were diarrhea. So the adverse events, they were generally the same in this preparation. So the adverse events, the serious allergic reactions like bronchospasm or swelling of the face were not observed, with NDLS in spite of no pre-medication. Whereas with conventional docetaxel, 2 cases of bronchospasm and 3 cases of swelling of face were observed, and no clinically significant changes were observed in hematological and biochemical parameter of NDLS population versus Taxotere. Neutropenia was consistent with those reported for Taxotere. This is another study 74014, and this was basically done to know about the doses of docetaxel. What is the tolerable dose of docetaxel from 16 milligram per meter square, 75 milligram per meter square, and 100 milligram per meter square. Every 3 weekly for 6 cycles they were given in CA breast, and the subjects, there were 30 subjects in each arm A, B, and C. You can see that the dose range was, so as we increase the dose of the docetaxel preparation with 60 milligram per meter square, the overall response rates were 21%. With 75 milligram per meter square, it was 34.62%, and 100 milligram per meter square, the patients, they had complete responses as well, and the total response rate was 48%. This is another clinical trial, and this is for the global clinical development of docetaxel preparation for the data being presented to US FDA. Being done on the patients who have triple negative breast cancer, locally advanced or metastatic, after failure of prior chemotherapy. So this is still recruiting, and the data is not available, but this is the clinical trial schema for these patients. This is locally advanced metastatic CA breast, total of 657 patients over a number of different centers. A multi-center study, a multinational study is being conducted, and the drug dose range used is 75 milligram per meter square of docetaxel versus 100 milligram per meter square of docetaxel versus 100 milligram of Taxotere, which is a standard of care in the breast patients. So more about clinical development of docetaxel, the data being presented to DCGI in various clinical settings. So 2 of these clinical trials, they have been completed in squamous cell carcinoma head and neck, a single arm multicentric open labeled efficacy and safety study of docetaxel preparation for squamous cell carcinoma patient head and neck. This has been completed. Similarly, another study in non-small cell lung cancer patient of docetaxel has been completed, and it has been presented to DCGI. 2 studies in metastatic CRPC and another study in gastric carcinoma patient, adenocarcinoma patient. They are currently open and they are actively recruiting. So this is the TPF induction chemotherapy regimen in locally advanced inoperable squamous cell carcinoma, in which instead of conventional Taxotere as a DCF preparation, docetaxel has been given. And the study outcomes are overall response rates, disease control rate, PFS, and overall survival. And these are the baseline demographic features of these patients. Median age somewhere around 50 years, male, female equally divided. And all the patients, they are Asian, and these are height, weight, and BSA for these patients. So at 2 years, the PFS and overall survival rates were 82.5% and 97.5% respectively in intention to treat population. Asthenia, alopecia, neutropenia, diarrhea, leukopenia, anemia, vomiting, anorexia, pyrexia, they were more frequently reported. And grade 3 or 4 infusion reactions and hyperglycemia or neuropathy were not reported in these patients who received a dose of Equalib. Similarly, this is another clinical trial which has been completed and the data has been presented to DCGI of 80 patients in non-small cell lung cancer. These patients, they were basically randomized into 75 milligram per meter square of dose Equalib versus 100 milligram per meter square of dose Equalib. All the patients were non-small cell lung cancer who had failed to previous chemotherapies, and primary endpoint was overall survival, PFS, and response rates. So this is a trial schema. Total of 102 patients were screened and 22 screen failures were there. 1:1 randomization between 2 doses of Equalib was done. And these are the population in which the drug has been studied. So this is PFS at 12 months and the safety of the drug. At 1 year follow-up, the PFS in NDLS 75 milligram and 100 milligram per meter square was similar, that is 8.07 and 8.13 month respectively. Overall survival and PFS for both arms was similar, that is 98% and 31.5% at 1 year. Median overall survival not reached in both arms. Most patients did not require any kind of steroid pre-medication. Anemia, leukopenia, abdominal pain, diarrhea, vomiting, asthenia, pyrexia, anorexia, they were more commonly reported. And only 2 events of grade 3 neutropenia, 1 in each arm, was noted in these patients. This is another drug, oral cabazitaxel, which is being developed by Intas. And the inclusion criteria are advanced breast cancer, head and neck cancer patients, lung cancer, melanoma, gastric, colon, and prostate cancer patients, in which the drug is being trialed in phase 1 clinical trial to look for a viable option in those patients who have progressed on multiple lines of treatment. So this is my last slide. Coming on to the take-home message, serious adverse events like hypersensitivity reactions are very common with conventional docetaxel, and to avoid them, we need to use corticosteroid as a pre-medications. Steroid can cause worsening hyperglycemia and increase risk of infection. NDLS is free from solvents and can be administered without steroid pre-medication. No grade 3 or 4 hypersensitivity reaction they were observed despite no steroid pre-medication. It has shown the promising efficacy in NSCLC and can be administered at 100 milligram per meter square dose. And oral cabazitaxel could be a new management option for the patient with relapsed refractory cancers. Thank you so much for your patient listening.
Thank you, Manish. Thank you for giving such a nice talk on newer innovative molecule of these chemotherapeutic drugs. Thank you. Thank you.
Thank you.
So here we come to the end of this CME program. And before saying some closing remarks, I would like to thank our academic partner, Liliac Insight, AstraZeneca, Faginas, Lupin, and Zydus also for participating in this CME. And of course, Mr. Tarun, Horizon, and Mahima, Ankit for organizing such a wonderful CME program today. And to end my session, so I would say that we have learned today that in carcinoma lung advanced stage cancer, so we have definitely come a long way in last 10 years or so, and we are able to use the higher dose of chemotherapy with the innovation like nanoparticle technology, not only lung cancer, in so many other cancers also, say ovarian, prostate, and GI malignancies also. So this is a one innovation in chemotherapeutic Another is that we have so many actionable druggable targets. And for this, whether we should do the targeted method of EGFR analysis like ARMS PCR or DDPCR, which we have discussed, or we should switch over to comprehensive genomic profiling. So all these highlighting points were discussed very well in this CME. And our area of using this targeted therapy is increasing day by day. So I'm sure that newer drugs will come up in future for better outcome in our patients. So this is actually an era of personalized treatment for lung cancer and all malignancy also as well. So thank you all. I close the session over here.
Thank you, sir.
Thank you so much,
Yeah,
sir.
thank you. Thank you, Ankit. Thank you, Maina.
Okay, support team, you can close the session.
Thank you.